There we go. Okay. So sorry. Hi guys, welcome to the ED teaching for Addenbrooke. My name's Jo. I'm one of the registrars, the ST4s at Addis. I'm going to be talking to you a little bit about pulmonary embolism today and risk assessing in the ED. If you can turn on your cameras and say hello, because it's very lonely here on my own. That would be really helpful so we can have an interactive discussion. Otherwise, this is going to be pretty boring. I'm going to try and make this not dry and a little bit interactive, so that just so that it's not an hour of yawning. Okay, let me share my screen. Nobody wants to say hello. Where are my slides gone? Okay. So, as emergency physicians, we make decisions about risk for patients all the time, and I think it's important as you become qualified that we appreciate how we're interpreting test results and how we then relay that information to patients in real terms. I was sat in a journal club this week with Adrian Boyle. I'm sure you've met him, and we discussed an interesting paper on pneumothoraces, large pneumothoraces, and it was a paper looking at how the management of large pneumothoraces, it was two cohorts, it was a RCT, it was a randomized control trial, and they were looking at conservative management versus interventional management. And so half the cohort received no intervention with a large symptomatic pneumothorax, and the other half had chest drains inserted. And they followed them up, I think it was either 3 or 6 months later, I can't remember. They followed them up, I think it was 28 days, yeah. And to look at the outcomes. And it was really interesting that the outcome in terms of was no different in both groups. However, what was different was the complication rate and the experience of the patients and those who'd had chest drains and those who'd been managed conservatively. And I think we had this discussion about what we would want if this was put us in the patient's shoes, having that information to know, actually, would I want intervention? Because very often people just go along with what the doctor says and on off and off, and well, I need a chest drain, so here we go. But actually, are we using the most up-to-date evidence? So are we providing our patients with up-to-date evidence so that we can give them, so that they're fully informed when they make decisions about their care, and involving them in that discussion. So one of the areas I thought I would focus on today is pulmonary embolism, because of D-dimers being such a controversial topic, shall we say, and how, as emergency physicians, we have to assess risk all the time and tell our patients about what their test results mean. And I think we should be having more in-depth discussions and allowing people to make informed decisions about the level of risk involved in accepting a negative D-dimer or positive. So that said, let's start. So that's the reasoning behind this talk anyway. I think it's very interesting, but we'll see if you think so too. So how important is pulmonary embolism? Well, the annual incidence is 60 to 70 in every 100,000, with half the cases occurring in hospital or long-term care settings, and that's obviously linked to their increased risk with being bedbound. Patients who are post-operative and those with malignancies are a particular risk, and there's a large cohort of patients who are admitted acutely, which is why we all have to do a VTE assessment. They will be the bane of your life once you become an F1. And actually 25,000 patients die every year in the UK from preventable hospital-acquired VTE. So it's important that we recognise it. And the in-hospital mortality ranges from 6 to 15%. So it's pretty significant. And I thought I'd add a little bit in here because it comes up quite often in the emergency department. Pregnant ladies are often referred to the emergency department as a query PE. and we're asked to make clinical decisions and risk assess those patients as well. And so why are we so concerned about it in pregnancy as well? Well, it's the third most highest cause of mortality in pregnant women as well. So although it's just above 1 per 100,000 maternities, but they are young, fit, healthy women who have childbearing age. So for it to be the third, it comes before hemorrhage. And I was shocked at that, because I would have thought that hemorrhage would have been a greater cause of mortality in pregnant women, but actually PE is greater. Just to remind you of the types of PEs. So we have the massive PEs. They're the ones where the patients come in usually in cardiac arrest, or they're shocked, or they're hypoxic, and they've got evidence of right heart strain. When you do an ultrasound, you see that dilated right ventricle, and they go into circulatory collapse. And the risk of death within 90 days is 50%. It's very high. The next category is your submassive PEs, where your patient will have significant shortness of breath and chest tightness, chest pain. And then your pulmonary infarction. So these are the ones that present with your pleuritic chest pain. So it's a bit of a misname. Everybody thinks chest pain, PE, but actually you have to have, it's usually your peripheral, more likely to be one of your peripheral PEs that presents with pleuritic chest pain, not your large PEs. And it's this group of patients that actually pose most difficulty, because they're usually low risk and have more diagnostic difficulty. So why is risk assessment for PE so difficult, and why do we get it wrong? We often see it in the news that we missed a large PE, we sent somebody home and they died of a pulmonary embolism. So why is it so difficult? And so you guys may, as part of your training, have been had I can't remember which stage you have it. I think it's in your 4th year. I think that's when we did it, when you're introduced to the concepts of sensitivity and specificity. And just to remind you, often it's quoted the spin and snout. So if you have a highly sensitive test like a D-dimer, and it's negative, then you can rule out, it's implied you can rule out that diagnosis. And the same with a highly specific test. Something like a pap smear that's very, very specific, and you get a positive, then you can rule that diagnosis in. But there's some problems with using spin and snout. Whilst I, as an emergency physician, I appreciate keeping things as simple as possible, and a way that you can remember things on the shop floor is always my goal. You can be caught out with just using sensitivity and specificity when you're advising your patients about how useful or what their test results mean. So the pitfalls to so it's talking about D-dimers and PEs. If we were to say that D-dimer has a sensitivity of, it's around 95%, the confidence intervals overlap. And that's telling us how reliable that test is at picking up PEs, as you know. So 5 out of 100 would not be captured by that test. So how are we ruling out a PE? What a patient really wants to know, and if I was on it, is actually asking about the negative predictive value. So what's the probability that if my test is negative, that I truly don't have a PE? And your sensitivity isn't telling you that, because this depends on not only the prevalence or the pre-test probability, so what risk category you fall in initially, but also on the specificity as well of the test. And we all know that D-dimer's got a very low specificity, around about 39%. So it's really, you can't really use sensitivity and specificities alone. Is everybody following me? Is this really dull and interesting, or I just hope it gives you like how we need to think about these things when we're giving patients results. Is everybody okay? Everybody with me?
Yes.
Yeah. So there's been a turn really in the last few years to look at likelihood ratios, which are more, I find, more helpful in helping you explain test results to patients. And I thought we'd just have in the chat, just have a little think about what 3 clinical features do you think increases someone's likelihood of it being a PE? So you can use examination findings, symptoms, what 3, just write down the top 3 you think would, if I have these 3 things, then there's an increased risk that I have. a PE, or the likelihood of them having a PE. Just write in the chat what you think your top 3 were. While you do that, I'm just going to quickly check that there's nobody else I need to let in. I'm going to pause the share. Oops. Meant to do that. So we've got some answers. We've got tachypnea, crackles, tachycardia, hemoptysis, tachycardia. Yeah. Anybody else? Chest pain, hemoptysis, shortness of breath. So they're the 3 things you're classically told, aren't you? As your presentation of PE. So I looked, so some things that you may have come up with. So the chest pain, dyspnea, immobilization, surgery, active cancer. Yeah, somebody mentioned what things that are within the Wells score. So they have a current DVT, syncope, cough, pleuritic chest pain, leg pain, pregnancy. And just to remind you of the definition of a likelihood ratio. Sorry, this slide is very busy, but in summary, it tells us how many times more likely you're likely to observe a positive result or a positive sign in a person with a PE than in a healthy person. And the likelihood ratios are quite useful because they're not dependent on prevalence, although you do have to, when you calculate someone's risk, you do have to take into account your pre-test probability to the prevalence. But that's different to negative predictive values where you do need to know prevalence. And just to give you an idea, so a likelihood ratio greater than 10 gives you strong evidence of ruling in a disease, and the lower you down, the weaker the evidence is. So this paper that I just looked at all the likelihood ratios from features of clinical history, and if you can see, they're all pretty low as individual risk factors. So there's nothing, the highest one is syncope actually at 2.38, but then that confidence interval, if you can see, is from 1.54 to 3.69. So that 95% confidence interval is huge. So you could be as low as 1.54. And the ones that we had, so chest pain, it could be less than 1 with that 95% confidence interval. Having a current DVT is round about 2. The same with the leg swelling. And shortness of breath is 1.83, sudden shortness of breath. Pleuritic chest pain is 0.894. And hemoptysis, something you mentioned, that is 1.62. So actually, they also looked at the clinical examination findings, and the most, so tachycardia, somebody mentioned, is 1.33. But actually shock is one of the most, is the highest likelihood ratio, but again, that is only 4, and the confidence interval there is exceptionally wide. It's 1.84 to 8.96. So none of them are above 10. So again, this is weak at best. This is weak evidence to rule in a disease. So this is why it's so difficult in predicting pulmonary embolism, and why we're constantly faced in press about missing these diagnoses, because it is difficult. There's no clinical feature that can be used in isolation to rule it in or out. And it's even harder in pregnant women who are already breathless and they're already tachycardic because they're pregnant. So it's one of these areas that's a real grey area, and is really hard as an emergency physician trying to get it right. So where does this leave us? So what we're currently at the moment, and I'll go on to it in a bit, is the nice release guideline in 2000, and they were looking at using, because prior to this, the PERC rule wasn't actually validated, and people were using it without actually having validation. And I think I've learned something by teaching this today, because often people will apply the PERC score before the Wells score. However, if you actually read the small print of the work, the PERC test, it only rules out PE if you've got a pre-test probability, so a prevalence of less than or equal to 15%. And so what we should be doing is determining what your pre-test probability is of a PE. And usually that's what we use as our clinical judgment. Or you can use something that helps you determine pre-test probability, like the Wells score. So if you have a low Wells score of 0, then you apply the PERC score. You actually then bring your post-test probability down to less than 2%. And that's kind of accepted as an acceptable low risk standard for ruling out a PE. And I think it's really important when you have these discussions with patients about their test results, that you document their individual risk assessment in the notes, so their individual Welsh criteria, their individual PERC score. And you have to always remember that there is no validated risk score for pregnant women. Even if anybody tells you there's a modified version that you can apply D-dimers, you really, really cannot apply any of this to pregnant women as well. And so it is still some diagnostic uncertainty, but I think this is the best that we're going to get at the moment. And that's what NICE in the 2000 guidelines recommended. So this is so you do your Welsh score, you do your PERC score. If your Welsh score is more than 4 and you're already, so your pre-test probability is high, you've already decided actually there is a likelihood this person has a PE, you progress straight to imaging. There's no D-dimers at all. You wouldn't, you're not in your low risk category. You would proceed to do a CTPA, and then if your Welsh score is less than 4, then we know you can apply the PERC score, or you can go on to do a D-dimer. So I think this chart is quite helpful. I haven't covered in this talk. There was also some guidance, NICE guidance released in 2000 about age-adjusted D-dimers, because as we age, we're more likely to have a raised D-dimer, just to do with the pathological processes that are ongoing. And so there is, it's a very, very long document. I tried to have a look at it today, but I gave up because I thought it was a bit too much for this talk. But it is interesting also that it can be the reliability of D-dimers as well, depending on age, can impact as well. And then there are some pitfalls to D-dimers. So as we said, they can be high for a number of reasons. That's why they have a low specificity. And they're not, you cannot use them in pregnancy, trauma, malignancy, inflammation. And they may fail to even, you may have a false negative if somebody is on anticoagulants. And this is just talking about that pre-test probability. You have to have a low pre-test probability before to use them. It cannot just be one rule applies to all. And also you have to, so in a lot of emergency departments use point of care D-dimers, and it's important that you also realize that they have a lower sensitivity and specificity, just as that specific test, than your standard lab ones. And so you have to, it's important when you start your new jobs that you have an idea of what tests they're using, how and where that test falls, because how you're advising your patients about the meaning of their test results is may differ depending on how sensitive that test is. So yeah, I hope I've illustrated to you how difficult this is, and it's probably one of the reasons why chest pain remains one of the consultant sign-offs. So even as a registrar, unless it's at night, I still have to discuss every case of chest pain with a consultant, because there is such diagnostic uncertainty. ECG changes in PE, how helpful is this? As you'll know, the most common ECG change you may see in PE is a sinus tachycardia. The S1Q3 T3. I've seen many people present with an infected toe with S1Q3 T3, and so it doesn't necessarily indicate PE. What's more, I think, if you have somebody you clinically suspect you've got a high test probability, if they have any non-specific changes, evidence of right heart strain, you need to take that really seriously, and everybody should have their ECGs to be looked at very, very carefully, and if there's any whiff of any heart strain at all. And because often you won't be able to get a CTPA overnight, and you will give them some low molecular heparin and bring them back in the morning. But if there's any evidence of any strain, then they should be admitted. In pregnancy, again, it can be normal to see a sinus tachycardia on an ECG. They can have left axis deviation. And you may not be familiar with looking at ECGs in pregnant women, so I think it's always worth running these past your consultant, past the senior, when you're, particularly if you're sending somebody home without investigation, and that's common in the emergency department. You'll see that CTPA isn't readily available, and so you treat and you bring them back the next day, which involves a certain amount of risk. So any questions up to that point? I think kind of discussed the initial clinical examination symptoms and initial sort of ruling in, ruling out tests. Any questions on that so far before we move on to imaging? I think this is also useful in pregnant women, just to have an idea what we should be doing, how we image them. No questions? Okay. So imaging in PE, there are two main types of imaging that you will come across. The gold standard is a CTPA, so CT pulmonary angiogram. It is the one that's most readily available, but there has been, and there continues to be, concern about the radiation exposure to young female breast tissue, and so VQ scanning, looking for ventilatory perfusion mismatch, is what's usually recommended. It's a lower dose of radiation. So if somebody is young, that's usually preferred, but these are not as readily available. And sometimes you have to then go on to do a CTPA because it's unreliable. So you have to have a normal chest X-ray to be able to proceed initially. And if you haven't got a normal chest X-ray, unfortunately, a VQ scan is not possible. But it is a lower radiation, so should be considered in young women, even in young men. Actually, I shouldn't say young women. In the young. And I just wanted, so this is always a contentious issue in pregnant women, how we investigate those. All pregnant women should have a chest X-ray. They can, there is a small amount of radiation, but if you then find a pneumonia on there, you have a reason for your shortness of breath. And you don't need to proceed to do further imaging, which is more radiation. It's important to do, I've put this on here just so that you're aware that when you're discussing with your patients which imaging is the best for them, particularly in pregnant women, it's important that we have an understanding about how radiation is often quoted. So it may be quoted in millisieverts or it may be quoted in milligrays, and that's down to do with the so the milligrays actually looks at the absorbed dose, the specific organ, and so it depends on where you're imaging. But the millisieverts only gives you the effective dose, so it doesn't give you actually the the radiation effect on the patient itself. So actually, if you can quote it in milligrays, that's more useful, and I'll go on to talk about that in pregnant women in a minute. So looking at the radiation risk, just to give you an idea, particularly in pregnant women. The fetal dose during a chest X-ray in milligrays is 0.01. Just to give you an idea of what the threshold of radiation needed to cause a miscarriage, we're talking about 50 to 100 milligrays. To causing congenital abnormalities, we're talking above 200. So you do need significant radiation, and so that's why I say to you that you don't need to worry about doing a chest X-ray in a pregnant woman, and it may give you the result that you need, and you won't need to go any further. Looking at the fetal dose that you get with a CTPA, that's, again, it's low. It's 0.005 to 0.1 milligrays, which it's obviously not as low as a chest X-ray, but it is still pretty low compared to the threshold needed for causing significant damage to the fetus. A VQ scan, however, is 0.9, so that is, it is more damaging to the fetus. But if you do a half dose, then it's 0.1. But you need to have a normal chest X-ray to be able to do that, because having that normal chest X-ray, you're assuming that the ventilation is normal. So you're getting rid of that part of the test and then bringing that down to 0.1, so it's equivalent to a CTPA. And just to compare that to what you get from doing an abdominal X-ray or a CT pelvis, you can see a CT pelvis is a significant higher dose in milligrays, and then abdominal X-ray is 1.4. So I think when we're discussing imaging with patients, it's important that we know what the risk is, and how best to advise them in those circumstances. And as we talked about earlier, the risk to pregnant women of PE is significant, and so it's in 2019 I've written European Cardiology. I'm not sure that's the full. They released a statement talking about how low the exposure to breast tissue was, and so the effect on maternal cancer risk, actually, it's no longer justified given the significant risks of PE in particularly in pregnant women, avoiding that on the grounds of maternal cancer risk, given that actually the radiation dose is quite low. I hope I've explained that properly, but it's the same then dose with a VQ scan, but it obviously, patient has to be aware that if the VQ scan is inconclusive, they may have to go on to do a CTPA anyway. I hope that makes sense. Does that make sense? Hello?
Still following.
You are? Yeah. It's quite complicated. Maybe I shouldn't have done this for a Wednesday evening. Just showing you just some CTPAs, and obviously I'm sure you can see the large clot here. Can you see my cursor?
Yes.
Yeah. So this is quite, it's not I wouldn't say it's a saddle embolism, but you can see there's significant clots in both pulmonary arteries there. And there is some, this is on the sagittal view. And just looking, this is what you'll see with a VQ scan. They're looking at the perfusion and the ventilation and seeing if there is a mismatch between the two. And here's an example. So you can see that ventilation here is good, but perfusion there is an issue. There is a mismatch here. So this is a VQ scan performed on day 1 postpartum, and there's a ventilation perfusion mismatch to the mid and lower zones during hypoxia. But you can, as I say, get an indeterminate result, which looks a little bit like this, which you would then have to go on to do a CTPA because it's inconclusive. But this is somebody with COPD, so that's why you need to ensure that you have you would have a normal chest X-ray before proceeding. So in summary about a VQ in pregnancy, it's low radiation to the fetus to begin with, as we said, is equal to the CTPA. You can use a normal chest X-ray to assume normal ventilation and avoid that part-2 so that you get less radioisotope. And you can do a half-dose Q scan, as we talked about, which is 0.1 milligrays. The only downside of a VQ scan, and this is particularly important for women who, if they're really postpartum, is that they need to discard their breast milk for 12 hours after the scan, which is really significant. If that person was 1 day postpartum, if you're trying to breastfeed, and you now have to wait 12 hours, it's going to have a significant impact on that bonding time with your baby and breastfeeding. So it's very difficult. And so it is something to have a discussion with the patient about. So it's important to have that discussion with breastfeeding mums, because it's something significant to take into account. Okay, right. So that's imaging, and then I thought we'd talk a little bit about management. And really, management we can split into 2 parts. So, is the patient stable? Is the patient unstable? And sometimes knowing if a patient is unstable is actually quite difficult. I now, we had one serious event recently in Addie's, where a patient collapsed in the toilet. She was a query PE awaiting CTPA. We were awaiting troponin. I didn't really show significant evidence of right heart strain on their ECG. But it is important that these patients don't ambulate, that they don't get up and go to the toilet, because they then, unfortunately, as soon as they stand up and they mobilize, they collapse. And so if there's if I remember we were talking about clinical features, syncope is one of them. If these patients are dizzy on standing, they really shouldn't be getting up and mobilizing around the emergency department, because there's a risk that they will go into circulatory collapse if they increase their venous return. So if you have a hemodynamically unstable patient, try and get an echo. We try and do bedside echoes on these patients to see if there's any right ventricular dilatation. And they may then be candidates for thrombolysis or embolectomy if thrombolysis is contraindicated. Obviously, they're anticoagulated, but that's only going to prevent you getting more clot. It's not going to sort out that initial clot that is sitting there in your pulmonary artery. And they may be considered for an IV filter. But it's more important about the observation of that patient, because if you know that patient is likely to become unstable, they need to be in a higher assessment area. They need to be observed. They need to likelihood to be on level 2, level 3 care. If they're hemodynamically stable, try and get them imaging that day if at all possible. We try and assess the severity in terms of if there is any right heart strain, and we start them on anticoagulation. Like I said, it's not going to prevent you that clot. It'll only prevent further clots, not actually the breakdown of the current clot. That we're relying on the natural processes of the body to break that down. This is taken from the NICE guidelines, the most recent ones. So if you and it's to do with if there are certain if anybody has any chronic renal problems, then you aren't able to use certain anticoagulation. You also need to take into account if somebody has active cancer or any conditions that put them at increased risk of clotting. That certainly you need to use certain different anticoagulation. One important point is that all patients that you're going to start anticoagulation should have a PTA, PTT, but you can start the anticoagulation before the test result is available. So usually in our department, we put people on low molecular weight heparin and we bring them back the next day for their scan. But some places may use a DOAC, and that would take effect immediately. If somebody has instability, and something that I learned looking at this was that actually using unfractionated heparin whilst you're waiting to go and get that scan, and considering thrombolytic therapy, so thrombolizing them to remove the clot. You can use unfractionated heparin whilst you wait for that. And obviously you wouldn't be considering thrombolytic therapy in people. Giving thrombolysis is not an easy thing to do. It has significant, it can have significant, so people can have a significant bleed as a result of it. So it should only be given if somebody's become hemodynamically unstable. You wouldn't consider thrombolysis in a patient who was hemodynamically stable. And I thought we'd just talk a little bit about anticoagulation in pregnancy, because this comes up a lot. The new DOACs have not been tested in pregnant women, so they can't. So rivaroxaban, apixaban cannot be used in pregnant women. Warfarin crosses the placenta, so you can't use warfarin. But actually, you can use warfarin in breastfeeding because it doesn't go into the milk. So once they're postpartum, you can use warfarin, or what's most commonly used is low molecular weight heparin, which doesn't cross the placenta, but you might need higher doses. And that's basically it. What's the time? Sort of a whistle-stop tour of PE and risk assessment. I hope it's been useful. It certainly is something to think about if you've got ED as one of your jobs, because you will be advising people on what their blood tests mean, and I don't think it's good enough now that we just say, oh, your D-dimer is negative, home, you don't have a PE. I think we need to be having these discussions about risk with our patients. I hope I've illustrated to you that the signs and symptoms of PE are unpredictable, and just to have my general advice would be always have a low index of suspicion. If anybody has malignancy, any risk factors, we should be investigating these patients fully. You will have a high test probability, and we should be doing CTPAs, if obviously unless they're young, but in anybody sort of over 40, we should be doing we should be investigating these people, and if you've got any inkling, we should be imaging them. Remember that if they've had recent admissions, they're at a greater risk of PE. And when you're on your daily ward rounds, it is really important, especially those patients on the geriatric wards who are sat in bed, that their legs need to be looked at every day. We need to examine them if they're bedbound for VTE, because it's a significant occurrence in hospital. We do cause PEs and DVTs by admitting people to hospital, because A, they're medically unwell, and B, they're less mobile. So it is important. I would encourage you to look at all your patients' legs on ward rounds. We've gone through the D-dimers and the predicted scores and how and how to use those. Chest X-rays and ECG is safe to do in everybody when you're trying to decide how to proceed. As I said, it's important to discuss the risks and benefits of imaging with patients so they can make informed decisions about what's right for them. And then we've gone through the management of stable, unstable. If there's any evidence of heart strain, so a raised troponin, any evidence of heart strain on the ECG, or if you're on echo, then they should be admitted and observed in a high dependency areas. These patients are at risk of going off and becoming unstable. I got recently caught out. The end of the bedogram. Does this patient look like they're going to have a significant PE? And she was 22, so she was young, fit. Came to the emergency department. She'd had recent immobilization following a knee injury, and she'd come in presenting with shortness of breath. She felt a bit dizzy on standing, shortness of breath and chest pain. But she was a young, fit, active university student. And so just looking at her, you would think, well, what are the chances of having a significant PE? But actually, when her ECG, I was very shocked when her ECG came to me, and was really surprised. She had right heart strain on her ECG. She had some signs of some T-wave inversion in V123, which in young people that can be normal, but I think in this context it couldn't be ignored. And then we did a troponin, and actually her troponin was raised, so she did have a significant PE. Now, at the time it was 4 o'clock in the afternoon, and they'd said, well, we can do a VQ scan tomorrow, just bring her back tomorrow and we'll do a VQ scan tomorrow, because obviously CTPA at the time in her age group wasn't the most appropriate investigation for her. So I was, in the end of the bedogram may have swayed me towards actually sending this lady home, giving her some low molecular weight heparin, come back for your VQ scan tomorrow. But actually the decision I discussed it with one of the medical consultants, and thankfully we brought her in for observation, because her troponin did turn out to be raised, and there was a heart strain on her ECG. So just the end of the bedogram is not good enough in deciding if somebody's PE is significant enough that they may go into become unstable. So always do troponins in these patients, and if you can, do an echo to see if there is any evidence of right heart strain. And that's it. Any questions? And I'm conscious I've talked at you for a long period of time. Look in the chat. So just wondering clinically how much you take into consideration the actual D-dimer value, I suppose, whether it's high or low. No, we don't really. The only time that I say that's of significance is when it kind of comes back as above 5,000. When it comes above the range, then in my experience, that correlates more with somebody has a PE or a DVT. And I don't know, and I've never seen anybody with above sort of the 5,000 threshold, and then it's turned out they don't have one. But those intermediate values we don't really use. So yeah, no, it really is it negative? If it's really positive above the threshold, then my experience is that correlates with it being a PE, with them having a VTE. But in between, we don't really take that into consideration. And especially with age as well. The values are different depending on your age, and people are starting to look at that now. But at the moment, it's not really filtered through. That recent night scan hasn't really filtered through into the emergency department, so you might not see people really know about the age-related difference D-dimers. Cool. Any more questions? It'd be interesting for me to know if you actually found this in, and I will not be offended in any shape or form if this was a bit too dull or too actually outside of the remit of what you guys need to know now. Do tell me, because it's good for us to know that we're giving you appropriate teaching. I find it interesting because it's important for my job to have an appreciation of what I'm advising people. And if you do have a medical job, an acute medical job or an ED job in your first year, you will be advising people on these results. And I think you will also have part of your communication skills, be able to discuss risk and results with your patients. So I think it is important for you guys to start early and have an understanding as to what kind of things we need to be discussing with patients. But I fully appreciate if it was just too much, do just let us know, or let Vaz know, and we can adjust accordingly. Anyway, I hope that was useful, and you can email Vaz or email me if it wasn't. Let us know, and we can change it. So I think there will be another one next week. I'm not quite sure who it's going to be. It won't be me. I'm due to go on maternity leave shortly. So but thank you for listening. Take care.